Well, thank you again for having me. Again, my name is Joseph Findley, and today we're going to be talking about polycystic ovarian syndrome and androgen disorders, and we hope to take a practical approach. I have nothing to disclose. So starting off with some definitions, hyperandrogenism is briefly defined as a medical condition characterized by high levels of androgens in females. These elevated levels of androgens result in acne, hirsutism, and can result in infrequent or absent menstruation. Hirsutism is briefly defined as the presence of excessive terminal hair growth in a male-like pattern. It can affect 5 to 15% of women, and it has significant psychosocial impact on the individuals who are affected. With hair growth, the overall number of follicles in an individual is fixed around 22 weeks of gestational age in their embryonic development. Overall number is similar between sexes, and there are differences that have been appreciated between races. Hirsutism results from a change in the character of the existing hair. When looking at the hair growth cycle, 3 particular stages occur. Anagen, which is a period of continual growth, catagen, which is a period of rapid involution of the hair bud, up to 2 weeks, and telogen, a period of quiescence that can last up to 4 months. Together, this process takes up to 6 months. At the end, telogen hair is shed when the new anagen phase begins. When looking at the 3 different types of hair that occur, the first type that we look at is lanugo. Lanugo is defined as fine, soft, short, or lightly pigmented hair that is often seen in fetus and the newborn. This hair is androgen independent and can often be seen in individuals who have anorexia nervosa. Vellus hair is defined as fine, lightly pigmented adult and prepubertal hair. This hair is also androgen independent and is seen in patients with hypertrichosis or excessive hair growth. This is prominent in non-sexual areas, as seen in this patient with hypertrichosis who has growth of hair on their back. It's most commonly familial, and it can be caused by systemic disorders or medications. Terminal hair growth is thick or coarse, long, dark adult hair. This hair is androgen dependent and occurs in a male-like pattern, typically on the abdomen, chest, or along the jawline. With hirsutism, androgens stimulate conversion of vellus to terminal hair irreversibly. They increase the rate of growth, diameter, and pigmentation of this hair. An increase in time is spent in the anagen phase in the body, meaning that this hair stays around for a longer period of time. And there's a decrease in time spent in anagen phase on the scalp, which can result in male pattern hair loss. Estrogens, on the other hand, produce finer, slower growing, and less pigmented hair. With hirsutism, peripherally, there can be issues where the end organ is too sensitive to the circulating androgens. This is something that is genetically determined, is like the follicle density and activity of 5-alpha reductase at the level of the follicle. Centrally, too much androgen can be produced. Additionally, exogenous administration of androgens can result in an increased level, ultimately yielding hirsutism symptoms. When these androgen levels are elevated significantly and persistently, it can result in virilization. This state of androgen excess causes symptoms consistent with hirsutism plus deepening of the voice, temporal hair loss, a male body habitus, breast atrophy, clitoromegaly, which is a clitoris having a length greater than 10 millimeters in length by greater than 35 millimeters. This is defined as the clitoral index, and can ultimately result in alterations of the lipid profile. When virilization is present, it is always pathologic. So looking at the androgens themselves, they come from different sources. Androstenedione is often thought to be an androgen precursor and is released from the ovaries and the adrenal glands, coming from a 50-50 distribution. DHEA is an additional precursor that is thought to be 10% ovarian in origin and 90% adrenal in origin. DHEA sulfatase is thought to be 100% adrenal in origin. And this we'll talk about the significance of this here shortly. Testosterone, one of the most potent circulating androgens, is thought to be 25% ovarian in origin, 25% adrenal, 50% due to peripheral conversion of androstenedione and DHEA. DHT is the most potent androgen. It is the result of 100% peripheral conversion at the level of the end organ, essentially at the level of the skin near the androgen receptor. Here, 5-alpha reductase converts testosterone, the most potent circulating androgen, to DHT. DHT can then stimulate the dermal papilla to convert vellus to terminal hair, as we described earlier. Hirsutism can have a number of etiologies. When a patient has hirsutism in normal menses, causes include familial, physiologic causes, including precocious puberty, pregnancy, and menopause, idiopathic causes, and medications can result in this condition. These include medicines like phenytoin, diazoxide, ACTH, or other corticosteroids. Hirsutism with irregular menses can come from a number of sources as well. When it results from an ovarian cause, conditions that can cause it include PCOS, ovarian neoplasm, such as Sertoli-Leydig cell tumor, granulosa cell tumors, or luteoma, hyperthecosis of the ovary, and chronic anovulation. Adrenal causes include adrenal hyperplasia and adrenal neoplasm, and pituitary causes include hyperprolactinemia, Cushing syndrome, and acromegaly. This is just a brief summary of what we just talked about. When looking at the etiologies of hyperandrogenism, far and away the most common cause is polycystic ovarian syndrome, accounting for 82% of patients with hyperandrogenism. We'll start off by talking about some of the more uncommon causes first, though we will get into PCOS shortly thereafter, and that will serve as the meat of our discussion. So talking about uncommon and rare causes, congenital adrenal hyperplasia is one of the most commonly discussed, and it can result from a variety of mutations, including mutations in enzymes 21-hydroxylase, 11-hydroxylase, and 3-beta-hydroxysteroid dehydrogenase. Androgen-secreting tumors, such as ovarian and adrenal tumors, can result in hyperandrogenism. Severe insulin-resistant syndromes are things that we'll briefly discuss, as well as Cushing syndrome and idiopathic hirsutism. So here we have a picture of the hormone biosynthetic pathway. At the very top, we have cholesterol serving as the principal precursor to this pathway. Cholesterol is then cleaved into a variety of different hormones that will ultimately downstream result in our sex steroids. When dealing with congenital adrenal hyperplasia, the three enzymes that are affected that will result in this condition include 3-beta-HSD or 3-beta-hydroxysteroid dehydrogenase, 21-hydroxylase, and 11-hydroxylase. If there's a defect in any one of these areas, it will result in an accumulation of the precursors or the things upstream and a deficiency of any of the hormones downstream. When looking at mutations in these enzymes, the most common cause of congenital adrenal hyperplasia are mutations in the 21-hydroxylase enzyme. These account for approximately 85% of cases with congenital adrenal hyperplasia, and for our purposes will be what we discuss primarily today. 11-hydroxylase mutations account for approximately 10 to 15% of patients with congenital adrenal hyperplasia, and patients in this category will be differentiated from patients with 21-hydroxylase deficiency in the fact that they have buildup of 11-deoxycorticosteroid and 11-deoxycortisol. Ultimately, these patients will have a more severe phenotype compared to 21-hydroxylase deficient patients and will often have an increase in the presence of hypertension due to the buildup of 11-deoxycortisol. Patients with 3-beta-HSD deficiency are thought to be significantly more rare and account for approximately 5% or less of patients with congenital adrenal hyperplasia. Recently, experts have argued whether or not this condition exists in a severe form, as it would thought to be almost incompatible with life. If patients do have a 3-beta-HSD deficiency, it's most likely a partial deficiency, and they will have a more severe phenotype or an elevated phenotype compared to patients with 11-hydroxylase and 21-hydroxylase deficiency. Non-classical congenital adrenal hyperplasia is a result of a 21-hydroxylase deficiency, as we just talked about. Because 21-hydroxylase is deficient, it will result in an accumulation of 17-hydroxyprogesterone. Patients with this can have early onset hirsutism, including premature adrenarche. This will often be seen in a familial pattern, and there can also be seen in certain ethnic groups that are thought to be at higher risk, including Hispanic race, Mediterranean, Slavic, and Ashkenazi Jewish race. In the early follicular phase, a 17-hydroxyprogesterone level less than 200 nanograms per deciliter excludes congenital adrenal hyperplasia. Levels greater than 800 nanograms per deciliter confirm this diagnosis. And levels greater than 200 nanograms per milliliter and less than 800 nanograms per deciliter require ACTH stimulation tests to further confirm or deny the diagnosis. Androgen-secreting tumors are rare causes of hyperandrogenism. Transvaginal sonogram should be performed for ovarian tumors. Adrenal CTs should be performed to rule out adrenal adenomas. When adrenal adenomas are appreciated, most are thought to be malignant. Bilateral disease could represent metastases, infection, pheochromocytoma, or amyloidosis. And routine adrenal CT is not recommended for patients with hyperandrogenism, as an incidental discovery of an adenoma can occur in 3 to 10% of patients. When discovered, fine needle aspiration can be helpful, but extreme caution should be taken because pheochromocytoma should be ruled out first. When there is a question of whether an adrenal cause is the source of hyperandrogenism, selective ovarian venous catheterization can be considered to help differentiate between stromal hyperthecosis from an ovarian tumor versus an adrenal cause. Ovarian tumors typically will have a rapid onset of symptoms, months rather than years. They're more likely to produce virilization, and they typically patients will have a serum testosterone level greater than 200 nanograms per milliliter. This can be suspicious, but it's not specific. Patients with adrenal tumors will often have a DHEAS level of greater than 700 micrograms per deciliter. For this reason, DHEAS is a key marker for adrenal androgen secretion because it is, again, 100% released from the adrenal glands. Patients with severe insulin resistance syndromes can have a variety of phenotypes. This is a very rare condition, and the phenotypes can be the result of defects in insulin receptors, autoimmune disorders, or a variant of what is called hair-on syndrome, or hyperandrogenism, insulin resistance, and acanthosis nigricans syndrome. Patients with this condition will often have skin tags as a result of increased insulin levels. Insulin is a growth factor and results in increased skin deposition in particular areas of the body, particularly around the neck and in the axilla. It can result, these patients will typically have normal insulin receptors, and their fasting insulin levels will typically be elevated. Cushing syndrome is a condition where there is an excess of glucocorticoids. The prevalence is very low, less than 1% in women with hyperandrogenism. And the 4 etiologies resulting in this condition include exogenous glucocorticoid administration, pituitary ACTH secreting tumors, cortisol secreting adrenal tumors, and ectopic ACTH or corticoid releasing hormone production by bronchial or other type of malignancies. Patients with Cushing syndrome will have a variety of symptoms, including hirsutism, central obesity, severe fatigue and proximal muscle weakness, skin atrophy, hyperpigmentation and easy bruising, man facies, a buffalo hump, typically located on the back of their neck. And this is seen in portion D of the image here to the right. Abdominal striae, which is typically described as purple striae, as seen in image C, as well as hypertension. When Cushing syndrome is suspected, we must first exclude exogenous administration of glucocorticoids. Once that's been done, it's typically recommended to perform one of a number of tests. One can perform a 24-hour urinary-free cortisol test. This should be performed twice to validate the result, or an overnight dexamethasone suppression test, or a late-night salivary cortisol test, which should be performed twice. If the results are normal, then it is unlikely that the patient has Cushing syndrome. If the results are abnormal, then you should use a second different test of one of the ones listed above to confirm or deny the test. If the results are discordant or unequivocal, then you need to repeat the abnormal test and then perform a midnight serum cortisol and or dexamethasone cortisol releasing hormone test. If that comes back abnormal, Cushing syndrome is diagnosed. If it comes back normal, Cushing syndrome is unlikely. If your second different test shows concordant abnormal results, then Cushing syndrome is diagnosed. Once Cushing syndrome is diagnosed, then we have to figure out whether the condition is dependent upon ACTH administration or not. So we check a plasma ACTH level. If ACTH levels are suppressed, then we think that the elevated level of glucocorticoids is likely secondary to an adrenal tumor, meaning that the ACTH is independent of the cause of the Cushing syndrome. If ACTH levels are elevated, Then we have ACH-dependent Cushing syndrome. And some of the aforementioned tests can be considered. Specifically, a CRH stimulation test can be performed. A high-dose dexamethasone suppression test can be performed. These are to help parse out what is the source of the glucocorticoids. If these tests are concordant and they show a response, then you have a diagnosis of Cushing's disease, and a pituitary MRI should be performed to look for a potential tumor. If there is a discordant response or a negative response, petrosal venous sinus catheterization can potentially be performed. If there is a gradient showing an increased level of ACTH, then we should again look for a cause in the pituitary and perform an MRI. If there is not a gradient, meaning that there is less ACTH being released from the pituitary, then we should look for an ectopic cause of ACTH release. Idiopathic hirsutism is hirsutism in patients with regular menstrual function and normal androgen levels. This occurs in 5 to 7% of hirsute patients, and is probably caused by increased 5-alpha reductase activity at the level of the end organ. Many women previously in this category would have been labeled as PCOS. However, with the new diagnostic criteria for PCOS, we can parse these groups out, and we'll talk about those diagnostic criteria here in a bit. So the diagnosis of a patient with hyperandrogenism can be sought out by looking at a number of different factors. History is key. It can give us an idea of the timing and nature of onset of hyperandrogenism, family history, menstrual pattern, signs and symptoms of androgen excess, methods of hair removal and frequency that the patient employs, potential medications that could be a cause, as well as evidence of other endocrine dysfunction, such as acromegaly, thyroid dysfunction, insulin issues, and elevated levels of cortisol. When looking at physical examination, quantification of sexual hair should be performed, and this can be done by using the Ferriman-Gallway scoring system. Abdominal and pelvic examinations can assist with looking for evidence of virilization and clitoromegaly, and evidence of androgen excess or other endocrine dysfunction should be employed. Essentially looking for evidence of striae, evidence of acanthosis nigricans, evidence of excess hair growth as described above. So this is the Ferriman-Gallway system, and it is a way that was created to standardize how increases in sexual hair growth can be described. This system looks at hair growth in a number of different areas and grades them based on the level of hair that is present. Though it is effective and it is a standardized way to describe hair growth in different patients, it does have some limitations and things that must be considered. This score can vary by race, and it does not account for cosmetic measures, including patients plucking hair, shaving, removing hair by other methods. It does not necessarily correlate to the level of distress that an individual patient experiences. And there's only a modest correlation between the circulating androgen levels and the quantity of hair growth. Additionally, there is a large amount of intra-observer variability with the scoring system. Laboratory studies that could be helpful include things like TSH and prolactin levels, total testosterone levels, a morning 17-hydroxyprogesterone level, a DHEA sulfate level, other clinically indicated labs, and a transvaginal ultrasound. When treating patients, it's important to explore what their expectations are so that you can help them reach their goals. Treatments include things like mechanical and cosmetic depilation, as well as hormone treatment with oral contraceptive pills, Depo-Provera, various androgen blockers, various GnRH blocking agents, and glucocorticoids. Looking at mechanical and cosmetic options, patients can shave. If their hair is dark, bleaching may lighten the appearance of the hair and can help improve patient distress. Patients can pluck hair. They can use laser treatment. Electrolysis can be considered for hair removal, and a medication called Vanica could be considered. With this type of treatment, no significant reduction may occur for up to 6 months. Oral contraceptive pills result in an improvement in 60 to 80% of patients. The important thing here is to consider the hair cycle that we discussed earlier. The hair growth cycle takes approximately 6 months from the initiation of hair growth to the point where the hair follicle dies. What treatment with oral contraceptive pills does is it helps reduce the creation and growth of terminal hair from new hair follicles. It doesn't necessarily treat the hair that is already present. So it's important to counsel patients and manage their expectations, as it can take approximately 6 months to see the maximum benefit of oral contraceptive use. All low-dose pills with 20 to 35 micrograms of ethinyl estradiol are thought to be equally effective. They result in a decreased level of luteinizing hormone, an increased level of sex hormone binding globulin, and this acts almost like a sponge in the circulation to bind up and inactivate free testosterone. This medication can also result in antagonism at the 5-alpha reductase at the level of the hair follicle and the androgen receptor, and this is performed by progesterone within the pill. Depo-Provera works by decreasing LH levels, and it can increase intrahepatic clearance of testosterone. Spironolactone is an effective medication in this sense as well. It's an aldosterone antagonist and a mild diuretic. It competes with androgens for the 5-alpha reductase enzyme at the level of the hair follicle. It competes with androgens at the level of the androgen receptor. And it can also increase sex hormone binding globulin. This medication can inhibit 5-alpha reductase directly in small amounts. When patients are started on this medication, the typical initiation dose is thought to be 50 to 100 milligrams twice a day, and then increased by 25 micrograms as needed. Side effects with this medication are small, though they can include things like dyspepsia, nausea, fatigue, polyuria, nocturia, headache, sun sensitivity, and decreased libido. And this is best used as a second-line form of treatment in combination with oral contraceptive pills. Patients on this medication should have an effective form of contraception in place if they are sexually active, because this medication may result in feminization of a male fetus. So for my patients, my typical place to start for patients with concerns for excess hair growth would be to start with oral contraceptive pills. And then if they are not satisfied with the results after 6 months of treatment, then I'll add in spironolactone as a second-line therapy. Progesterone acetate is an androgen blocker that is a derivative of 17-hydroxyprogesterone. It also inhibits gonadotropin release and is a competitive androgen receptor antagonist. It inhibits androgen synthesis and is used as a European oral contraceptive pill, is used in the European oral contraceptive pill Diane. Finasteride is another medication that can be used to help with increased hair growth. It's a 5-alpha reductase inhibitor that is used for benign prostatic hypertrophy in males and hair loss. This medication inhibits type 1 enzymes to a limited extent, and it may cause feminization of a male fetus through the type 2 receptor. The effective dose is 5 milligrams daily, and it has the least amount of side effects with these compared to these medications, but it's also thought to be the least effective. Flutamide is a potent androgen receptor blocker that is used in prostate cancer. It's effective at doses of 500 milligrams daily, though you can start with a lower dose of 250 milligrams. Side effects with this medication include dryness of the skin, as well as loss of scalp hair. Patients can also have green urine with liver function abnormalities. This should be a huge red flag if patients are taking this medication, as in rare cases, it can herald fatal hepatotoxicity. And this is a medication where liver dysfunction is thought to be a significant side effect. Other options include treatment with medications like GnRH agonists. These medicines are very effective, and they have a profound ability to drop serum androgen levels, and they can be used with estrogen add-back therapy in order to mitigate some of the menopausal side effects that patients can have while on these medicines. Utility of using these medications, however, is limited by cost and these many menopausal side effects. It may be useful in the treatment of patients with ovarian hyperthecosis, though it's not fully effective because insulin-resistant issues can help, or can result in progress of hyperthecosis. Glucocorticoid medications are key to be used in patients with congenital adrenal hyperplasia because those are the hormones that are lacking, and they are downstream of the enzyme block. Though these can be effective in patients with non-classical CAH from a hair growth perspective, they're still thought to be less effective than oral contraceptive pills and anti-androgens. Topical medications like Vanica, also known as eflornithine hydrochloride, can be used, and these inhibit ornithine decarboxylase at the level of the dermal papilla or hair follicle. These medications are best suited for patients with mild facial hirsutism and can be used concurrently with laser therapy or other depilation methods. So now we get to polycystic ovarian syndrome. This is a condition that was first described by Vallisneri in 1721, when he saw a young married peasant woman who was modestly obese and infertile with 2 larger than normal ovaries that were bumpy, shiny, and whitish, just like pigeon eggs. It wasn't until 1935 when this condition was further described by Stein and Leventhal in a paper that they presented at the Central Association of Obstetrics and Gynecologists. In their paper, they had a case series of 7 patients with amenorrhea and sterility. They used pneumoröntgenography, which is X-ray of the abdomen with following installation of air into the abdomen to demonstrate enlarged ovaries. As the enlargement of the ovaries was felt to be the primary issue with this condition, they performed bilateral wedge resections, where they removed 1/2 to 3/4 of each ovary. Of the 7 patients that were seen, all 7 had normalization of menses following wedge resection. Of those 7, 2 conceived, and their case series included a follow-up period of 11 months to 4 years. Clinical features of polycystic ovarian syndrome include oligo or amenorrhea in approximately 78% of patients, though approximately 18% will have normal menses. It will include hirsutism. Patients will have an increase in acne and oily skin. Some patients may experience androgenic alopecia. Obesity is common with android fat distribution, and patients will often present with infertility due to anovulation. Endocrine features of this condition include an elevated level of luteinizing hormone, normal follicle stimulating hormone levels, an increase in the luteinizing hormone to follicle stimulating hormone ratio of greater than 2.5. This used to be something that was diagnostic of PCOS. However, this has fallen by the wayside. It can still be helpful occasionally in parsing out patients with PCOS from patients who simply have anovulation due to obesity. Patients with PCOS can have elevated testosterone levels, elevated DHEAS levels. They may or may not have elevated prolactin levels. And one of the markers of this condition is an increased risk of insulin resistance. And we'll talk about the significance of all of these things as we go along. In an attempt to further define this syndrome, an expert panel convened in 1990 to help define major criteria. This panel with the National Institute of Health here in the US labeled the major criteria for PCOS as hyperandrogenism and or hyperandrogenemia, oligo-ovulation, and an exclusion of other known disorders. In 2003, the European Society for Human Reproduction and American Society for Reproductive Medicine convened at Rotterdam to help further define this syndrome. And they defined PCOS as a patient who has at least 2 or 3 of the following criteria: oligo or anovulation, clinical or biochemical signs of hyperandrogenism, and polycystic ovaries. In 2006, the Androgen Excess Society attempted to define this syndrome further and said that having this syndrome requires the presence of hyperandrogenism and either ovarian dysfunction or polycystic ovaries. In 2009, they further defined their criteria as requiring the simultaneous presence of hyperandrogenism, either clinical or biochemical, and ovarian dysfunction, as seen by ovulatory dysfunction or PCO morphology on ultrasound. And we'll discuss what these things mean here in just a little bit. So here is a chart with all of these different criteria. The most commonly used are the Rotterdam criteria from 2003, where 2 of the 3 criteria need to be met to have a diagnosis of polycystic ovarian syndrome. So when we talk about polycystic morphology on ultrasound, what exactly is a polycystic ovary? In 2003, at the Rotterdam Convention, it was defined as greater than 8 follicles measuring less than 10 millimeters arranged around the periphery of the ovary and an ovarian volume measuring greater than 10 cubic centimeters. This is identified by looking at the ovary in one field. So this is not the entire ovary, it's one view. In 2006, the Androgen Excess Society felt that it would be more appropriate to define this as greater than 12 follicles measuring 2 to 9 millimeters in diameter in one view of the ovary. In 2013, an international consensus statement was released regarding this topic. It was previously felt that the prior 2 criteria were felt to be too inclusive, and it led to too many patients being diagnosed as having polycystic ovarian syndrome. At this consensus statement, they felt that there should be an increased follicle number per ovary rather than in just one view, and usually the number that's used as a cutoff is greater than 20, though more conservative cutoffs of greater than 25 have been used in the past. The follicles that are present should be similar in size, and they should measure between 2 and 9 millimeters in diameter. And this is the definition of an antral follicle. The ovaries, the follicles within the ovaries should have a peripheral distribution or have a classic string of pearl distribution and appearance within the ovaries. And there should be a background ovarian enlargement greater than 10 milliliters in volume for each ovary. More recently, it's been described that these diagnostic criteria should be adjusted for adolescent females. These are females within 8 years of menarche or age less than 20 years. This is because these findings are so common in young females. Thus, it's felt that ultrasound should not be used for the diagnosis of PCOS in adolescents. So when looking at the ovaries, regardless of which criteria you look at, what we're looking for are a number of small antral follicles, approximately 2 to 9 millimeters in average diameter, that exist in the periphery of the ovary. And this is, you can see the classic string of pearls appearance around the periphery of the ovary with relative sparing of the middle of the ovary. So you have relative sparing of the ovarian stroma. This is thought to be due to an increased population of theca cells in the middle of the ovary, and ultimately these result in an increased level of androgen production. This morphology is thought to be due to a self-propagating cycle that occurs within patients who have polycystic ovarian syndrome. Unfortunately, we don't exactly know where this cycle begins. Ultimately, what we have as a result is follicle growth that arrests at the antral stage between 2 to 9 millimeters in diameter. We have an increase in ovarian stroma, so this central portion of the ovary here. With this, we have an increased level of androgens being released from the theca cells. And ultimately, this increased androgen levels in the patient's system result in decreased follicle growth, and the cycle starts over. So is it an abnormality at the level of the ovary, where the ovaries don't respond appropriately and the follicles don't grow? Or is it an intrinsic error with increased androgen production elsewhere? Other conditions associated with polycystic ovaries on ultrasound include some of the ones we've already talked about: congenital adrenal hyperplasia, androgen secreting tumors, hyperprolactinemia, any state of chronic anovulation, ovarian hyperthecosis, and other endocrine disorders such as Cushing syndrome or acromegaly. Essentially, adding high levels of androgens in at any phase can result in ovaries that have this appearance. Laboratory evaluation of patients with PCOS includes measuring a total testosterone level. The main reason we're doing this is to rule out a possible ovarian tumor. Checking a DHEA sulfate. Again, we want to make sure that there isn't an adrenal tumor. We want to check TSH and prolactin levels. And these are often checked if there is a coexisting menstrual dysfunction. We want to check some form of tests to look for insulin resistance or diabetes. And we'll talk about the significance of this here shortly. And we want to check a lipid panel. Secondary screening tests that can be considered but are not necessary in all patients include 17-hydroxyprogesterone testing, as 2 to 3% of hirsute patients will have congenital adrenal hyperplasia. This sometimes can be clinically indistinguishable from PCOS. When we check this, a morning 17-hydroxyprogesterone level should be checked in the follicular phase, as this level can be elevated after ovulation. A level greater than 200 nanograms per deciliter requires an ACTH stimulation test to confirm the diagnosis of congenital adrenal hyperplasia, like we discussed before. And levels greater than 1,000 nanograms per deciliter are thought to be diagnostic. LH and FSH levels Again, they are not diagnostic of polycystic ovarian syndrome, but they may be helpful with infertile patients to describe how their HBO axis is functioning. Tests with little to no clinical benefit include androstenedione, DHEA. As we talked about beforehand, these are very non-specific androgen precursors. And because levels are elevated, we're not sure if they're coming necessarily from the periphery, from the ovary, or from the adrenal. Sex hormone binding globulin levels and insulin levels are not thought to be helpful either. Though polycystic ovaries can be associated with the syndrome, they may be a marker of underlying endocrine imbalance, though they're not necessarily diagnostic of the syndrome itself. Again, these ovaries can be seen in patients with higher androgen and insulin levels, or patients who have lower sex hormone binding globulin levels, resulting in increased free androgens. There's a higher frequency of irregular menses in patients with polycystic ovaries, and hirsutism is more common, though, again, these findings are also more common in the adolescent population, and here they should not be used for diagnostic criteria for PCOS. This is a study that was performed in 1998, where they looked at patients with normal ovaries, or excuse me, without PCOS, and on ultrasound, they found that approximately up to 25% of patients can have polycystic appearing ovaries. So again, just because we see it's on ultrasound does not necessarily mean that the condition is present. The pathogenesis of this condition is complex and multifactorial, and it can be influenced by synergistic impact of the environment and predisposing genetic factors. There is found to be familial clustering, and there is a higher concordance in monozygotic twins compared to dizygotic twins, though no single gene has been identified as the causative agent. It can result from a number of pre- and postnatal events. Prenatally, exposure to elevated levels of androgens in non-human primates leads to an adult PCOS phenotype. Where I did my fellowship, one of the ways that we created a PCOS morphology in mice was to inject pregnant mice with elevated levels of androgens. The offspring were then found to have a PCOS morphology. Postnatally, premature adrenarche can be associated with hyperresponsiveness to ACTH, elevated levels of insulin and insulin-like growth factor, as well as decreased sex hormone binding globulin. Rapid weight gain in small for gestational age babies and sustained adiposity in large for gestational age babies can accelerate the pubertal appearance of polycystic ovarian syndrome. And there's also been found to be an association between high birth weight and polycystic ovary morphology on ultrasound. These pathologic features can potentially result from an insult that happens at any number of all of the levels shown here. There can be an increase in GnRH pulsatility. Rapid GnRH pulses result in an increased response to GnRH. When this happens, it results in increased LH pulse frequency at the level of the pituitary and tonic secretion of FSH from the pituitary. This increased LH release relative to FSH release results in increased ovarian androgen production in the theca. Ultimately, results in decreased sex hormone binding globulin release and increased insulin levels. Ultimately, this increased level of androgens stays in circulation longer because there's decreased androgen clearance, and there is enhanced 5-alpha reductase function in the liver and adipocytes converting testosterone to dihydrotestosterone. So what we end up with is sort of this self-propagating cycle where an insult in any one particular area can result in aggravation of dysfunction in the other areas. At the level of the hypothalamus, you can have aberrant secretion of LH and FSH, insufficient FSH to sustain folliculogenesis, as we described. The GnRH neurons, they are inherently pulsatile. Rapid GnRH firing in this situation favors LH release. When FSH release is relatively, when GnRH release is relatively slower, then we have a system that favors FSH release. So when patients with PCOS, LH release is favored over FSH release. So is PCOS caused by an intrinsic abnormality of the pituitary? LH pulse frequency remains elevated in the face of ovarian steroid suppression in GnRH analogs, according to one group in 1997. Theca cells from PCOS ovaries downstream are found to produce more androgens per cell than those from normal ovaries. An improvement in ovarian function is seen after ovarian wedge resection by these groups in 1995 and 1998. Therefore, the thought is simply reducing the amount of theca and androgen production in the ovary can potentially help to break this cycle. In patients with PCOS, adrenal androgens are also found to be increased. And 50% of patients will have an increased level of DHEAS. Increases in androstenedione and DHEA are commonly seen as well, and there's no one mechanism that explains these findings. Ultimately, we end up having patients with increased estradiol, and this causes decreased adrenal 3-beta-HSD activity, increased ACTH release, and increased sensitivity to ACTH, intrinsic upregulation of P450C17 enzymes. They convert androgen precursors like DHEA and androstenedione to more potent testosterone. And there's an increase in insulin. High local androgens that can contribute to the PCO morphology. 5-alpha reduced androgens cannot be aromatized, and they inhibit aromatase and also inhibit FSH induction of LH receptors on the granulosa cells. So again, we get this propagating cycle that we discussed earlier. So why is this important? And why do we care that there is increased levels of androgens, increased levels of insulin in the system? In 2003, a consensus statement came out that identified that women with PCOS were found to have not only increased levels of obesity, but also increased levels of metabolic syndrome. And to screen for metabolic syndrome, it was recommended to use a glucose intolerance test with an oral glucose tolerance test, as PCOS conforms a 4 times increased risk. The metabolic syndrome is a condition that looks at several different categories of metabolism, and when they are abnormal, they are found to confer a significantly higher risk for the patient from a cardiovascular standpoint. Metabolic syndrome is defined as abnormalities in waist circumference, triglycerides, HDL, elevations in blood pressure, and abnormalities in fasting and 2-hour glucose tolerance testing. The majority of patients with PCOS are obese, and though this level can vary in different populations. Some studies suggest that there is an abnormality of calorie utilization, but overall results of this are inconclusive. Body fat distribution for patients is most commonly shows an abdominal circumference with a greater than 35%, or excuse me, greater than 35 centimeters, and you have an increased waist to hip ratio, suggesting that there's an increase in android body fat. This is significant because it's associated with an increased risk for hypertension, non-insulin dependent diabetes, lipid abnormalities, and cardiovascular disease. So these illustrations here show the different types of body fat distributions that it can occur. And with PCO morphology, it is more common to have an apple-shaped or androgen dependent distribution of body fat, where the waist has a greater than 0.8 ratio compared to the hip circumference. Again, patients with PCOS have increased risk factors for cardiovascular disease, and this is thought to be due to increases in oxidative stress, endothelial cell dysfunction, and dyslipidemia. These patients are also at significantly increased risk for developing type 2 diabetes and gestational diabetes when pregnant. All women with PCOS should be screened for diabetes, though it's uncertain what is the best method to do so. Hemoglobin A1C can potentially be used at an elevated level greater than 6.4%, can be diagnostic of diabetes, though it should be confirmed with repeat testing. Levels of 5.7 to 6.4% can show and suggest impaired glucose tolerance, though it's not necessary, though this is not thought to be an effective diagnostic method for looking at insulin resistance. Fasting glucose levels are not recommended because they are not thought to be sensitive enough. And some groups still recommend using a 2-hour oral glucose tolerance test with a 75-gram oral glucose load as the diagnostic method of choice. Though in my practice, I've found that patients often have issues complying with waiting around for the 2 hours to have testing completed. Looking at insulin resistance, 65 to 70% of patients with PCOS will have insulin resistance. And of these patients, 80% will be obese. Not all patients are obese, however, as 25% are lean. Insulin is a growth factor, and it stimulates the theca cells and ovaries to produce excess androgens. It also augments the effect of LH on ovarian androgen production. Acanthosis nigricans is also an important thing to look at regarding insulin resistance. Less than 30% of patients with insulin resistance will have acanthosis nigricans. However, if it is present, greater than 90% of patients with acanthosis nigricans will be insulin resistant. So, though not all patients with insulin resistance will have it, if it's there, it is a significant marker. Acanthosis nigricans is also a significant marker because it's associated with other issues such as acromegaly, psychroid, Cushing syndrome, Addison's disease, cancers, including GI cancer and ovarian cancer, as well as increased administration of drugs, including corticosteroids and nicotinic acid. So if acanthosis nigricans is present, it's important to look for any potential causative issues. Going back to insulin resistance, again, there's no easy way to diagnose it. The gold standard for diagnosis historically has been thought to be the euglycemic hyperinsulinemic clamp. Unfortunately, this is not something that's practical in the outpatient setting and is really limited to research settings. fasting insulin levels and fasting glucose levels are not recommended because studies show that they did not correlate well with the gold standard. Additionally, insulin resistance can vary significantly with PCO phenotype. Insulin resistant assessment does not identify response to therapy or clinical outcomes. One of the most practical ways to approach this is knowing that this is something that is present in a high proportion of patients with PCOS, is to look at some of the associated conditions that go along with insulin resistance. And in this situation, it's safe to assume that a patient has some level of insulin resistance if there's a BMI level greater than 30, acanthosis nigricans is present, or there is polycystic ovary morphology seen on ultrasound. One of the reasons that we care about this is because there are some things that we could potentially do to help these patients out. And this includes use of insulin sensitizers. And of these sensitizers, metformin has been one of the ones that's been the most widely studied. Metformin is a biguanide medication that has a variety of mechanisms. It decreases hepatic glucose synthesis. It decreases intestinal absorption of glucose. It increases insulin-mediated glucose utilization in the peripheral tissues. And one of the main benefits of this medication is it does all these things, but does not cause hypoglycemia. Some of the side effects include gastrointestinal issues, including nausea, diarrhea, and abdominal pain. These things are the most common. And because of this, when starting patients on this medication, we recommend starting off at a low dose and titrating up to the desired dose. For patients with polycystic ovarian syndrome, we typically recommend titrating up if the patient will tolerate it to a dose of 500 milligrams 3 times a day. Metformin has historically been described as causing lactic acidosis in a very small population of patients. However, there are no reports of this happening in the PCO population. If it were to occur, symptoms you would be looking at would include things like fatigue, muscle pain, respiratory difficulty. And because of this, it's typically recommended that metformin be discontinued approximately 48 hours prior to having surgical procedures where there may be increased stress put on the liver. Insulin sensitizing medications in patients with PCOS can have a variety of benefits. Metformin, alone or in combination with medications like Clomid, have been found to improve ovulation rates and clinical pregnancy rates. Live birth rates, however, are not improved with metformin alone. Testosterone levels are found to be modestly improved in PCO patients who are taking metformin. All reported benefits of metformin, however, were found to be significantly less in obese patients with no significant long-term weight reduction seen. And there's no data to indicate that metformin itself decreases gestational diabetes or miscarriage rate. Metformin, may be used as a first-line therapy in patients with polycystic ovarian syndrome who do not want to use Clomid. The only advantage that it has for ovulation induction alone, however, is that it does not result that it is associated with a lower risk of multiple pregnancies compared to Clomid. Clomid itself does yield higher live birth rates, though metformin may be useful in improving ovulation rates in patients who are resistant to Clomid. Metformin is not recommended as an initial treatment for hirsutism, as both oral contraceptive pills and spironolactone have been found to work more effectively. And there is no data to suggest that metformin decreases development of type 2 diabetes or metabolic syndrome in patients with polycystic ovarian syndrome. In this situation, lifestyle modifications, weight loss, dietary changes have all been found to work better. Regarding lifestyle changes, weight loss of 10% of the initial body weight for an obese patient has been found to result in decreased insulin levels, increased sex hormone binding globulin, decreased free testosterone levels, improvements in hirsutism, improvements in menstrual pattern, improvements in lipid profile. Some patients will spontaneously ovulate, and this ultimately will result in increased responsiveness to medications like Clomid. So some of the additional medications that could be used for treatment of polycystic ovarian syndrome include oral contraceptive pills. If the patient's goal is not to become pregnant, this is a very effective first course of treatment. The mechanism of action of the oral contraceptive pills, just like the patients that we discussed earlier today, includes decreased LH stimulation of androgen production, increased sex hormone binding globulin production, decreased binding of dihydrotestosterone at the androgen receptor, possible decrease in 5-alpha reductase enzyme, and a decreased adrenal androgen production. Again, just like patients with hirsutism due to other causes, it will take approximately 4 to 6 months before seeing maximal benefit from an abnormal hair growth perspective. And when looking at birth control pills, there's no evidence of superiority of one pill over any other. In patients with polycystic ovarian syndrome, the benefits of OCP use outweigh the risks. And in the absence of other factors, women with PCOS are not at higher risk for complications of birth control pills. Just like patients we discussed earlier, spironolactone can be added in as a second-line treatment if after 6 months, OCPs do not provide the desired benefit regarding decreasing hair growth. Again, this is not some medication that you would want to put patients on unless you have an effective form of contraception in place. And again, treatments like eflornithine or Vanica could potentially be used to help reduce facial hair growth. Again, this has no effect on acne, but it can provide significant improvements in growth along the hairline, along the jawline. Patients with PCOS have been found to have higher scores on standardized testing for depression and anxiety compared to controls. And because of this, you should always consider screening for mood disorders. Regarding infertility, Clomid was initially tested as the medication to help improve ovulation. And as we discussed earlier, Clomid is associated with a higher rate of ovulation compared head-to-head with metformin. In this particular trial, Clomid resulted in a live birth rate of 22.5%, an ovulation rate of 49%, compared to 7.2% and 29% with metformin alone. This is the study where we found the interesting finding that adding the two together have a synergistic effect and can increase in both increased ovulation rate and a live birth rate. The new actor to this paradigm are aromatase inhibitors. Aromatase inhibitors have a shorter half-life compared to Clomid. They tend not to cause the thinning lining of the endometrium that may be seen with treatment with Clomid. It's more likely to have a monofollicular development. It's associated with fewer mood-related side effects compared to Clomid, and it may be successful in clomiphene-resistant patients. Additionally, for patients who have concerns regarding elevated estrogen levels, aromatase inhibitors are associated with lower peak estradiol. Disadvantages include they are more expensive than Clomid, and they are potentially teratogenic if they're given during pregnancy. A systematic review and meta-analysis performed comparing letrozole to Clomid showed that as a first-line therapy, there is no difference in pregnancy rate, miscarriage, live birth, or multiple birth rate between the two, and that there were no differences in any outcome comparing letrozole versus Clomid plus metformin. This paradigm changed in 2014, however, when a large double-blind multi-center trial involving 750 patients was performed. This trial compared treatment with letrozole versus Clomid in the polycystic ovarian population. And what it found was that letrozole was associated with both a higher live birth rate and higher ovulation rate compared to Clomid. This study showed also there was no significant difference in pregnancy loss, fetal malformations, or multiple gestations. And because of this, letrozole is felt to be the medication of choice for oral ovulation induction in patients with polycystic ovarian syndrome. For patients who are resistant to oral ovulation induction, meaning that there is no ovulation on Clomid up to doses of 150 milligrams, or letrozole on doses up to 7.5 milligrams, it may be reasonable to add in metformin if the patient's not already on it. In this situation, it's also reasonable to consider other options, such as adding in ovarian drilling, which we'll discuss here shortly, or gonadotropins, which are injectable medications geared towards helping the ovary produce a significantly higher number of follicles. Ovarian drilling is a surgical technique where unipolar cautery is used in a cutting current of 20 to 30 watts, is used to burn a portion of the theca. Here, the goal is to reduce the amount of theca in the center of the ovary that is thought to be the causative tissue resulting in increased androgen production. During laparoscopy, the goal is to create 4 to 10 punctures, approximately 35 millimeters in depth. Ultimately, you want to make sure that that you're able to avoid the hilum of the ovary, because this can result in increased injury to the ovary and an increased risk of bleeding. Hormone changes after this procedure include decreased LH production. Variably, we can see increased FSH production. Testosterone levels are thought to fall. Androstenedione levels are thought to fall. Inhibin levels temporarily fall. There's no change in sex hormone binding globulin, and there's no change in DHEAS, because ultimately this is a result of adrenal production. Risks associated with this procedure include post-op adhesion formation. There's some studies that suggest that ovarian reserve can be decreased. There are some reports of ovarian failure if this procedure is performed too aggressively. There's the associated generalized risks of laparoscopy and surgery. And additionally, this procedure does not always work, though it is relatively effective. If performed appropriately, 80% of patients will ovulate either spontaneously or could have ovulation with treatments like Clomid or letrozole. 65% of patients who ovulate will conceive. And we should see spontaneous menses or ovulation in 6 to 8 weeks post-surgery if the procedure is effective. If not, then we would move on to see if the patient has become more responsive to medications like Clomid or letrozole. So again, this is something that we would use when there is failure to ovulate with maximum doses of oral ovulation-inducing agents. It's very important to discuss the risks and benefits of the procedure with the patient versus proceeding to gonadotropins. which are not without their own risks and could put patients at significant increased risk of multiple gestation. It's used for patients who have polycystic ovaries on ultrasound, and you have gone through the algorithm and excluded all other causes of anovulation. So, in summary, polycystic ovarian syndrome is primarily a disorder of androgens and hypersecretion by the ovaries, a genetic disorder that is probably originates in the fetal ovary that becomes manifest at puberty. These symptoms are ones that persist throughout reproductive life. In addition to the standard gynecologic symptoms, patients are at increased risk for cardiovascular disease, dyslipidemia, type 2 diabetes, as well as mood disorders. Weight loss can be a very effective treatment and results in significant improvement in symptoms. And most patients will be successful in achieving pregnancy with appropriate treatment. So at this point, I open the floor for any questions.
Thank you, Joseph, for very comprehensive and detailed. I really congratulate you for putting all of these details in such a lecture. And I think we are waiting for Professor Shaaban to join because he will be moderating the question part.
I'm here, but you're not allowing me to be with my camera on. So,
okay. So, NG, can you
share my screen as well? Okay. Yes,
there we go. You are it.
Joseph, thank you very much for your very informative presentation. I had collected the questions, and I'm going to share with you.
Okay.
And discuss it one by one. Okay. Can you see my screen? Okay, let's start with the first question. If we have a patient with PCOS, has an obvious diagnosis with acne and hirsutism, should we do an androgen assay or not?
I think this is a very good question because as we described before in the Rotterdam criteria, you do not necessarily have to have biochemical evidence of hyperandrogenism. Clinical evidence of it can yield the diagnosis of PCOS. What the androgen assay helps you do, however, is it helps you rule out other causes of hyperandrogenism. So checking a testosterone level, making sure that it is not significantly elevated, can help you rule out an ovarian testosterone producing tumor. DHEAS, if it is not elevated, will help you rule out a adrenal androgen producing tumor.
So in your opinion, sorry to interrupt you, but in your opinion that we, before start treatment of any case of acne or hirsutism, even I so believe that this is due to PCOS, I should start with evaluation of androgen assay.
I think so, and the reason being is PCOS is ultimately a diagnosis of exclusion.
Well,
so in order to make sure, in order to fully exclude other more concerning issues, I think the checking androgen assays would help you do that.
This will lead us to the next question, which is question 2. What is a must to do an androgen assay? Here we are speaking about a case of hirsutism. So the answer is clear. Everyone should have an androgen assay. I'm right?
I believe if you have them readily available, it would be reasonable to proceed with that. It also kind of depends on what the presenting symptoms are as well. I mean, if you have somebody who's presenting just with acne, it would not be unreasonable to start an OCP or other treatments for something like that. If you have somebody presenting with significant increased hair growth and menstrual abnormality, I think it would be worth proceeding with the testing.
Again, in question 3, another question about androgen assay. Are there any recommendation before doing an androgen assay? I think the one who asked this question asking about precautions that should be taken during the assay, and what are the best time to measure the free testosterone?
I don't think any particular precautions, but as far as measuring testosterone is concerned, by and large, it's recommended to check total testosterone levels. The reason being, free testosterone is often something, though free testosterone is the active form of testosterone, the issue that we have testing it with female patients is that the assay is not designed to be very sensitive at female hormone levels. So the testosterone assay is much more effective and much more reliable at male testosterone levels, so levels of 200, 300, 400. It's not nearly as specific and sensitive at levels of 20, 30, 40. So because of this, the total testosterone level is thought to be a better marker of what's going on with that particular patient.
That's clear. Thank you. To go to question number 4, how can we deal with cases of hirsutism that have normal androgen levels? That the one described by you as an idiopathic hirsutism, and does lowering the normal level of androgens of any benefit?
So in this situation, if you have a patient with normal androgen levels in hirsutism, it may be due to increased sensitivity at the level of the end organ. So in that respect, treatments with things like OCPs or androgen blockers like spironolactone or finasteride, those things, though the levels are already normal, simply decreasing the amount of circulating androgens may reduce the stimulation at those overly sensitive peripheral receptors.
So they may
yes, even though what you're treating essentially is you're treating symptoms rather than numbers.
That's great. In question 5, what to do if the Assiut lady is also seeking fertility and not accepting combined oral contraceptives?
So the thing here is to really parse out what is going on with the individual as far as their menstrual cycle and ovulation is concerned. So you would want to do some evaluation and history collecting to find out if, is the patient actually ovulating? Are their cycles regular? And if they are found to be anovulatory, then it's a matter of evaluating to figure out what the cause of that would be. So we would want to double check and make sure there are not elevated levels of prolactin, make sure the thyroid hormone is within normal limits, and rule out any other potential pathologic or more pathologic causes for anovulation. Once that's done, different interventions that could result in ovulation and helping the patient become pregnant include lifestyle modifications. Again, a certain proportion of patients, if they are obese, will ovulate following 10% loss of their body mass. If patients would like to employ medications to help with ovulation, considering something like Clomid, or in the case of obese polycystic ovarian syndrome patients, letrozole, they could be used to help induce ovulation and help them become pregnant.
I understand that, but I understand this question in another way. How you can deal with the symptoms of hirsutism during you're seeking for fertility, because most of these drugs are teratogenic or potentially teratogenic.
I see. So I apologize. So things that you could use to help treat the hirsutism itself would likely be limited to mechanical methods of depilation, laser hair removal, things like that. Unfortunately, as you suggested, the other treatments that we mentioned would either be contraceptive or somewhat teratogenic in nature.
The local treatment is as well is potentially teratogenic. The local cream for the chin and so on.
I would have to take a look to see if Vanica is or not. That's one of the treatments that is less commonly used.
Less commonly used.
And part of the reason is it is not a very cheap medication.
Yes.
So Vanica, it says here that it may be used during pregnancy.
May be used.
Yes. It's thought to, it says inadequate human data available. So it does not have any recommendations to withhold from pregnant patients.
That's great. In number 6, we have a question here. Are there any pathophysiological explanation of increased possibility of hirsutism during pregnancy?
So one of the things that can happen is the ovaries may produce an increased level of androgens, or there can be a sort of, though estrogen levels are quite high, the proportion of progesterone to estrogen later in pregnancy can be associated with almost a functional reduction in estrogen, a functional reduction in estrogen action. And because of that, some patients will manifest that as increased hair growth or increase in acne. That's
great. In question 7, we have here a question. I think you have answered this during your presentation, but if we can repeat, what is the most simplified prescription for treatment of PCOS patient and hyperandrogenism in adolescents? And when can I start treatment? As you mentioned, in the new criteria of diagnosis of PCOS, they told us that this diagnosis is questionable before the age of 20. So if I came with an adolescent girl complaining of hirsutism, shall I start in combined oral contraceptives, or I should wait?
I think that it would be reasonable to start with contraceptives because they can help not only reduce the issues with acne and abnormal hair growth that may be causing significant distress to the patient, but if the patient is sexually active, they can provide contraceptive benefits from that respect as well. Additionally, if the patient is oligomenorrheic or amenorrheic, it can help to serve in a endometrial protection function to reduce the likelihood of them developing endometrial hyperplasia in the future.
That's great. In question 8, we all understand that the lifestyle modification is of benefit in treatment of patients with PCOS as regard infertility. What about hirsutism? If we have a lady or a girl with an idiopathic hirsutism or an hirsutism secondary to PCOS, does the life change may improve the hirsutism symptoms?
I think if their level of obesity is associated with hyperandrogenism, we do have evidence that lifestyle changes can reduce the level of theca and ovarian androgen production. So I think that it could have the ability to help that, but I don't know that that would unilaterally be helpful in all cases. So it's something that could certainly be tried, and in general would provide health benefit for the patient. But I don't know that it would necessarily be the sole treatment that would be needed for most patients.
Okay. In question 9, here one of the audience is asking about how to differentiate by ultrasound between the PCOS picture and ovarian hyperstimulation syndrome that may be secondary to the treatment.
Yeah. Can you repeat that one more time?
How similar PCOS with ovarian hyperstimulation syndrome, or one is apart from the other? They mean ovarian hyperstimulation syndrome usually having a multicystic ovary. How can we differentiate?
Got you. Okay.
Yes.
So a multicystic ovary compared to a polycystic ovary will be different in the fact that multicystic ovaries will have not only antral follicles measuring 2 to 9 millimeters in average diameter, but will have larger and smaller follicles present as well. So you'll see a more varied appearance of the follicles within the ovary, and the distribution of the ovaries of the follicles within the ovary will be different as well. So if you think of the ovaries like a chocolate chip cookie, if you will, a polycystic ovary will have the majority of the follicles in a string around the periphery of the ovary with relative sparing of the center. A typical multifollicular ovary will look more like a classic chocolate chip cookie, where there is somewhat even distribution of the follicles or the chocolate chips on the ovary. So it all kind of depends not only on size and relative size of the follicles, but also distribution.
That's great. That's clear. The final question I have here, I think we answered this question before, that the weight reduction in non-PCO idiopathic hirsute girls could improve the condition. Here, the correlation between the weight reduction and the hirsutism away from the PCOS. To my knowledge, there is no evidence about that, but do you have any comment on that?
Absolutely. So for patients who have anovulation that would typically come to see us, and we go through the workup and we define that their anovulation is secondary to obesity rather than polycystic ovarian syndrome, there is a significant increased chance of ovulation occurring with reduction in body weight. And part of the issue with obesity is that adipose tissue is a very large functional endocrine organ with increased levels of aromatase. And those patients, they'll often have increased levels of estrogen at baseline that can negatively impact the ability of the hypothalamus to function appropriately. And reducing that adipose tissue in many of those patients can result in spontaneous ovulation. And what we see is that for patients with a BMI level over 35, as body weight increases and BMI increases, there is a concordant decrease in likelihood of success of fertility treatments and likelihood that they will respond to medications like gonadotropins or oral ovulation-inducing agents. So many times, if the patient is able to be effective in weight loss and they're able to maintain a healthy weight, then they become not only more likely to respond and ovulate on their own, but also more responsive to medications in general.
Okay, by that I come to the end of the questions listed here. Dr. Bedaiwy, if you have any comments before we can conclude. Okay, it seems not here.
No,
By
I
that,
am.
yes,
So nobody's allowing me to share, but basically, I just want to thank Joseph. This is a very tough topic. It's a dry topic in reproductive endocrinology. People tend to give it. I used to talk about it myself when I was an assistant lecturer a lot. So sorry, Joseph, but you did a fantastic job actually, and you shared a lot of expertise and clinical tips that would be very useful to a lot of our audience. And it's a very good reference to our undergraduate students as well as residents and fellows. Very comprehensive. I really applaud you for the amount of hours and effort that you put to put this lecture together. That's my only comment.
I hope that you find it helpful and did not fall asleep. So
Thank you very much.
We didn't. Anything else, Dr. Shaaban, that you want to add?
I should repeat my thanks to Joseph for his time, and I can say good night in Egypt, and have a nice evening in USA, in Canada, and see you next time.
Thank you very much.
Remember, thanks, Joseph. Next time will be on June 13th, Dr. Liu, who will be talking about clinical aspects of amenorrhea. Thanks for your time and for your attention, and we'll see you on June 13th. Have a wonderful evening.